So I just got the skinny from Ms. Collins that you guys have been doing the clinical stuff for not that long, and that you've made it through anatomy. So congratulations.
Thank you.
We are going to talk about some ear, nose, and throat stuff. Ear, nose, and throat is the specialty of deep dark holes, and you need a big bright light to see whatever is going on. So it is scary. It makes up probably about 80 to 90% of what you might see in a family practice clinic. So it's a big deal. I will try to do the most important thing for you, is give you some confidence that you can figure these things out and make the right decisions for the patients. Do not be afraid of me. If you have a question, raise your hand, state your name. I won't remember it, but let's see if we can generate some kind of rapport here. We are going to go my specialty of otology. Just tell you how these things work. I did the medical school thing, and then I did the 5-year residency, and then there is a 2-year fellowship in just specializing in the ear. So I look at this much and ignore the nose and the throat, but I'll tell you how important the nose and the throat are. But I refer all of those things to my other partners and let them do those things. So, first question, anybody have a hearing loss in here? Anybody had an otologic surgery outside of tubes?
What?
I had some when I was a little kid, where they took a piece of skin from my ear and like patched something in my ear.
Okay.
I'm not sure what it was though.
Okay. Yeah, and that exchange that we had, so I give these 15 or 20 minute things called informed consent, and that's exactly what people remember. I kid you not. So, just get to, this is the savvy of patient interaction. Just tell them, the basic things, and then ask them if they understand and agree, and try to keep it very simple, because most people hear about 10% of what we say. And it might be, you might die, and it's like, I'm going to die. To which I say yes, because we're all terminal. Right? Okay, so we're going to go from the outside all the way to the brainstem, and I'll try to give you the things that you absolutely need to know so that you can be a little bit savvy on these things. So this is me. We're going to talk about the external ear otitis externa, which probably some of you guys have had. The reason I asked that question is because if you think you might have an interesting ear exam, I will bring this thing called a digital otoscope, and we will take a picture of your ear so that everybody can look at your interesting ear, because you guys are your own best teachers, right? So when you stick this in your friend's ear and you hurt the snot out of them, they will let you know, because they're going to stick it in your ear next. Okay. Speaker disclosure. The only thing I have to disclose is that I make money at practicing medicine and doing these surgeries. That's a good thing. Okay, so we're going to talk about the examination. How do you look in the ear? Have you guys looked in an ear yet?
Today.
Today. Very fresh. Let's move on. So we've looked in the ear today. So the best way to look in an ear is that you want to provide yourself some stability. Okay? So you've got a weapon here, and you're going to put a sharp point on the end of this weapon. So you get the patient, grab the top of their ear, and pull it 45 degrees up. That will straighten out the mobile external auditory canal. Your external auditory canal, which I'll show you a picture of, has a soft tissue component, and then it has a bony component. You do not want to touch the bony component. Anybody who would like me to touch their bony component in a controlled fashion will immediately be able to tell you why you don't want to do that. It's because there are two things in the bony component: nerve and skin. It has no forgiveness. So you're essentially touching nerve when you touch the external bony canal. So take the ear, pull it 45 degrees up, put your speculum in there, enough to get past the hair that is in the ear. Anybody know where ear hair comes from? This is the most fascinating genetic question ever. Ear hair comes only in males. It's one of the very few things on the Y chromosome. There you go. Aren't you glad you came?
That was one of the things, Blair.
Okay, so you place the speculum just past the hair, and that should be enough to see the ear canal and the eardrum. And then you want to look all the way around the eardrum, down to the ear canal, down to the eardrum, and you want to localize the malleus, okay, otherwise known as the hammer. We learned that in 3rd grade, but now we call it malleus, which is the first hearing bone. The first hearing bone is in the surface of the eardrum, okay? So you should see that. If you can't see that, then you diagnose loss of vesicular landmarks, okay? So there are certain landmarks that I will teach you, we will see, you will be able to name. I will consider it a failure if you don't know these things. And then on the malleus, you're going to be able to name the short process and then the umbo. Anybody know what the umbo is? It's the end of the malleus. Now there is this much talked about next thing that's not up there because I want you to forget it, called the cone of light. Okay? Anybody ever heard of the cone of light?
Yeah.
Okay. They're like, did you see the cone of light? It's completely useless, it means nothing. Okay, it just means that light is bouncing off the eardrum, but it doesn't tell you anything. If you ever read one of my notes, I have never made any clinical decision whatsoever off the cone of light. Okay? It is talked about, it is there, acknowledge it, but it doesn't mean anything. Okay? The short process is at the top, the superior aspect of the malleus, and it has some other important things, and we'll go from there. So once you see the eardrum, you need to do one of these. Anybody know what this is? It is a pneumatic otoscope. So it plugs into the side, and this one doesn't allow this. And this is probably the most important thing. So with your largest speculum, you don't want the smallest one that can fit in there. You want the biggest one that can fit in there. Why? Because you have a plastic focal thing here, okay? It's plastic. You're looking through one eye. You want as much light as you can get. And then you're going to gently puff this thing right here. And what that does is that it will move the eardrum if there is air underneath the eardrum. If there is not air underneath the eardrum, or if there's negative pressure, you can, through examining your friends, figure that out. So good hearing is accomplished by having, this is what we call a multimedia presentation now. So we have our eardrum, we have our eardrum, ear canal. You have the first hearing bone, the second hearing bone goes down to the stapes. Stapes goes off to the cochlea. Then you have the eustachian tube. Between here and here is what we call the middle ear space. Middle ear space is supposed to be filled with air in order to have good hearing. If it is filled with anything else, then you don't vibrate the eardrum the way that you're supposed to through the middle ear transformation system, and you have something called a conductive hearing loss. I see the remnants of air conduction greater than bone conduction here. So if you have a conductive hearing loss, then you're not moving your eardrum, and you have at least a 30 decibel hearing loss. Anybody want to give a guess from this morning's lecture as to why it's 30 decibels? The question 30 dB. So the reason is because the density of air and the density of water is roughly 30,000 times difference. And that difference, because when you look at this is air in here. What fills up the cochlea? Water, roughly perilymph, endolymph. That density difference has to be made up by the physics of the big eardrum funneled through 2 lever arms and a piston to a small window, so big window to small window. The physics of that make up perfectly the density difference between air and water, and so we lose no energy in the mechanical transformation of the sound vibrations to the inner ear. So if you've ever thought anything was totally cool, that's totally cool. We lose no energy. There's no better designed mechanical system than the inner ear. And we could go on and on and on, and some of tomorrow afternoon we will go on and on and on about the balance system and whatnot. Okay, so pneumatic otoscopy, pneumatic otoscopy, pneumatic otoscopy. Learn how to do it. Why should you learn how to do it? Because it is dependent upon the correct diagnosis of an ear infection. And we'll talk more about that later. I think I probably had a few more exclamation points to go here. Okay, so we have the standard equipment there. This is the wrong tuning fork. It's a 125, I think. Maybe. No, it's a 256. So this is middle C. You can learn a lot from tuning forks about the hearing. So you guys know what the Weber is, right? So your inner ear does not care how it gets its vibrations. So it only wants to activate the vibration pathway, which can begin anywhere. It can begin in your teeth when you go to the dentist, or it can begin in your office when you put the tuning fork on the top of your head. So I won't go through the Weber and the Rennet or Rene or however you say it. I don't know. We can talk about that a little later. So here's the external ear. So the external ear has soft tissue on the outer 1/3 of the length of the canal. It has bone and skin essentially on the inner part, or the inner 2/3 of the external auditory canal. And then we have our eardrum, the malleus, the incus, the stapes, the inner ear. The inner ear is completely encased in bone. Okay? So it's encased in bone because it does not need any other sensory input except through where the stapes makes the junction with the middle ear space. So one of the most frequent things that we do in our clinic, and this is a picture of our clinic setup, complete with 1960s trash can. I looked at this picture and I thought, the only thing you really see in this picture is the green trash can. But you know what? It works. It holds trash. So this is the picture of our clinic. So little kids will take whatever they can find and they will stuff them wherever they can. They will eat them. Anybody have kids? They do this, right? They eat them, they stick them in their ears, and they stick them in their nose. So if you're in a clinic and the parents are like, I think he has something in his ear. And you're like, yeah, I see something in his ear. Unless you have this equipment, I would highly encourage you to utilize your Rolodex and phone a friend. Because the last thing you want to do is make my job harder or put the little kid through some suffering. If it's a battery, so if it's a watch battery, any kind of battery inside the body is bad news. Okay? So a watch battery, usually a circle, and then it has a little spot here. And one side is negative, and the other side is positive. So you can pass the current. If you put two wet surfaces together, you can pass the current through the battery, and you can erode, melt away, burn the skin or the mucosa, and if it's in the nose, you can cause a septal perforation. If it's in the ear, you can circumferentially kill the skin all the way around the ear, and the body, it's exceedingly difficult to take a circle of skin and get it to be a circle of skin again. Because if you make a round puncture wound, what happens? It goes shoop and closes up. And it is a very, very hard job to get that thing to get the message that, no, we want this to go this way and not like this again. So if it's a battery in the ear, that's a call to an ear, nose, and throat doctor's office and say, I have a kid with a battery in his ear. And you don't stop until you get the answer, thank you, I'll send them right over. Okay? Everything else is kind of, okay, we can take care of that, when we can get to it. Bugs, and you will see if you can think of a bug, it will crawl in the ear. How do they get there? Sometimes the kids put the roly-polies in their ear. Sometimes they pick up the cockroach and they put it in their ear. Sometimes they put the earthworm in their ear. They just get there and we don't really care. I've stopped asking, we just take them out. But it can be quite distressing to have a live bug in the ear, as long as there is no tube in the ear, or a hole in the eardrum, or a history of chronic ear disease. You can pour, you can put with an eyedropper mineral oil in the ear, and the mineral oil will drown the bug. Actually, any liquid would drown the bug. But mineral oil is a little soothing, and that's okay. So the other frequent foreign body that we have in the ear is something that's natural, and what would that be? Wax. And so wax is really problematic because it gets in the way. Wax is made by the sebaceous units that are in the outer part of the ear, and we have lots of pictures of that here coming up. And also the outer layer of the ear canal and eardrum is skin. So that skin has a mobile, this is the only migratory epithelium in the external auditory canal, which is really cool if you think about it. But that skin has a migration pathway from the umbo up and out the external auditory canal. So most people's external ears are self-cleaning. So when, and there is a whole fascination with earwax. So people are like, I have earwax. I'm like, good. We have a name for earwax, and we call it normal. So there are a few patients who have, just unrelenting earwax, and they do have problems hearing because it accumulates. You will see as you begin to touch and examine patients that older people's ears are a little more difficult to examine. That's because of this thing called gravity, and everything in the human body goes south, including your ears. So your ears, because of the weight, they rotate this way, and they essentially can close the ear canal, and you can get a large amount of cerumen accumulation in the ear. So, how do you deal with earwax? God gave you how many eyes?
2.
2 eyes. So what I recommend is that that this particular Welsh Allen otoscope is completely useless for trying to remove earwax, because you can't stick anything through the place where you have light. This Welsh Allen otoscope is also completely useless, because you try to slide the window off to the side and stick an instrument through it, and then like, okay, the edge is right where I need to see. This is completely useless. So what I recommend is a trip to Academy or a trip to Walmart. I was at Walmart yesterday, and I purchased a headlight, 235 lumen headlight. And to get out wax, because most people are not going to have this really expensive microscope in this table to lie down and remove wax. And if you do, then you can develop the skill. Jeff Frederick, my physician assistant that I've worked with for the last 8 years, he can remove wax and clean out cavities and stuff, just as good as I can. If you don't have that, then what I recommend is this. So you take your headlight, and then this is a nasal otoscope. You take that nasal otoscope and you go like this, and it opens this way. And you spread it in the ear canal, and then you can gently scoop out with 2 eyes the wax in the ear. Okay? Why 2 eyes?
Because you got to.
Because with 2 eyes you get depth perception. Right? So, if you have a foreign body and you think, I think I can get this, same maneuver. And I would recommend that this is a Hartmann forceps. They'll have these in emergency departments, or they won't. If they don't, then phone a friend. But with 2 eyes and a nasal speculum, you can spread open the ear canal, and you can insert the alligator-like forceps, and you can grab it and you can pull it out. There is no there's no failure in having to call somebody. Okay, you can get over that right now. You don't have to know everything. You don't have to be able to do everything, but just don't hurt people. So 99% of my clinic can be done with the stuff on these 2 screens. Okay, so otitis externa. Otitis means what?
Inflammation.
Ear inflammation. Externa means what? Out. And where does the external ear begin? Auricle all the way to, yeah, to the eardrum. And then what's underneath the eardrum? What do we call that space? Middle ear. And then what do we call the space beyond the oval window? Inner ear. So patients all the time come in and say, he had an inner ear infection. Okay. We'll talk about that too. But okay, so the earwax is highly protective. So this fascination with I have to do candling, which is a great way to get into my clinic and really need to be there. You know, and cerumen removal kits and all of that. All of this fascination is really overplaced. So, you know, for some reason, you know, people love to take Q-tips and cram them in their ear. And we have great words for those things, but the only, you know, people are like, well, okay, well, how do I clean my ears? Well, you should clean your ears with your finger, with a washcloth over it, and go like this, and that's it. And that's really all you need to do. So, but they're like, yeah, but the wax dries up and falls out. Like, yes, 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 it does. It's okay, we have a word for that. It's called normal. Right. So this Apollo sebaceous unit, Apollo's sebaceous unit makes fat, lysozymes, sweat. The wax makes up a large component of this. It is acidic and it is protective because bacteria and fungi cannot grow in this environment. So deep, dark, moist places have a propensity to grow fungus and bacteria. So how do you stop that? You make it acidic and you make it self-cleaning. As we dry out, as we age, that's when we can be a little more prone to have difficulty. So all of the stuff that people want to dump in their ears and injure their ears with is actually self-promotive of this thing that we call otitis externa. So swimming to wash away the protective layer of the external auditory canal, all of the solutions and lotions and potions that people want to dump in their ears because they have wax. All of those things are really not very helpful at all to helping their ear be healthy. The best thing is just to leave it alone until you develop a hearing loss and then come in and see us. But most people don't do that. So risks, swimming, perspiration, high humidity. Guys and gals like Tinker who have to wear earplugs all the time. So, you know, anything that if you plug up the ear, then the humidity will rise, and then you're outside, you're working on an airplane, and then you get to see Dr. Berryhill because I have an otitis externa. I cannot tell you how many ends of Q-tips that I've removed from people. People who have eczema, psoriasis, you know, some kind of a dermatitis and acne, they will also maybe have difficulty with otitis externa. And so this is a picture of an ear canal. What you'll see is that it is red and swollen and angry, and it is very, very narrow and painful. So I hardly ever admit people to the hospital because I do most of my surgery is you get to go home the same day. But the last few people who have been on my service, they're like, "Who's Dr. Berryhill?" Oh, okay. The last few people who have been on my service have been folks with otitis externa. So it is exceedingly painful. So how do I know if you have otitis externa? You grab the outside of the ear and you just gently go like this. And if they hit you or come up off the table, good indication that they have otitis externa. So severe auricular tenderness. Not really the auricle itself, but usually it's confined to the lateral aspect of the canal. Sometimes it can go all the way down to the medial canal and involve the bone. We already said this, but, you know, I mean, it can just be really ugly. So, this is just a picture of just an ugly ear that is really angry. Most common causes are staph, Corynebacterium. These are things that are on your skin anyway. So staph, Pseudomonas, MRSA, so you know, you guys, does that ring any bells? You know what that is? Okay, so methicillin-resistant Staph aureus. We are creating and will suffer through what we have not had for 100 years now, which is a post-antibiotic era. So we are creating all of these drug-resistant organisms by overuse of antibiotics, and you know, we're going to be in big-time trouble because staph is, you know, highly resistant to some of these things. So use judicious use of antibiotics. Pseudomonas, Enterobacter, these are just the other strange things that can be found inside the ear. So symptoms, it itches like crazy. People just, they're like, oh, my ear. The external ear is like a chigger. Anybody know what a chigger is?
Yes.
Yes, what happens when you itch a chigger? It itches more. So the same thing for your external ear. You can get edema and swelling and debris. So what do we do for it? First, you know, pain control. So I've already told you that sometimes I've had to admit people to the hospital to give them IV pain medication as opposed to Norco or Tylenol or Percocet or something like that. So I have on here repeated cleaning of the ear. So what we'll do is, under our microscope with our speculum and our suctions, we will clean and debride the canal, because the canal cannot get better if it is plugged and we can't get the medication to and through the thickened, swollen skin. So we'll see them back like on Monday, Wednesday, Friday, Monday, Wednesday, Friday, Monday, Wednesday, Friday, sometimes for weeks in order to get them healed. But say that you guys are in Stringtown, and you know, anybody know where Stringtown is?
Yes.
Yeah. So say that you guys are in Stringtown, and you know, there's not an otolaryngologist around, and they're going to have to do, you know, a 2-hour drive to Tulsa or to, you know, Norman or whatever. What should you do? You should gently try to place a wick in the ear. So there are these things called Oto wicks. For lack of better description, they are tampons that are really tiny, and they are short, and so you will not damage the eardrum as long as you don't go beyond where you can see. But the idea of the Oto wick is that you take it, you know, just gently suction up and down some debris from the ear canal, and then you take our little friend, the little Hartmann forceps, which is the little alligator thing, put the wick on the end of it, and just tell them you're sorry, and you just push it through the edema, and then you fill it up with otic drops. So at this point, we don't know if it's a bacterial or a fungal thing. So usually I would begin the patient on cordyceps in order to fill up that sponge. So the sponge expands, fills up with antibiotics, and it delivers the antibiotics to the really thickened tissue. And then they can go see an ear, nose, and throat doctor. They can pull out the sponge, clean out the debris, and put in another sponge. And we may do that over and over and over. But you know, these are some of the things that we may use. Chloramphenicol, fungazone, sulfanilamide, amphotericin B, boric acid, acetic acid are a lot of the things that we will do. There's not, you know, sometimes we'll use an oral if we think that it's Pseudomonas, because it has this nice green, topical, debris collection.
You mentioned go ahead and sectioning.
Yeah.
Just with the normal section 2. Is that what you're?
Yeah, so, I'm assuming now that you're going to be, I'm assuming a lot. I'm assuming that you're at a place, that we're playing emergency room right now. So, you may have to ask for the, the Maringotomy kit or, something from the operating room. But what you're gonna wanna get is one of these angled nasal suctions. And so this nasal suction will come in 3, 5, or 7 French. So you're going to use the 5 or the 7, and you're just going to, with your thumb off the hole, because you put there's a hole right here, you put your thumb over the hole, and that occludes the suction 100%. You're going to, put that in, just kind of feather your thumb over the hole, suction out, some of the debris, and then, right where you were, you're going to slide this small Otoquick. I'll see if we have an Otoquick in clinic, and I'll try to bring it tomorrow, along with the otoscope that I forgot, and the map to this place. It's amazing I found it. I looked at it once, and those are very good directions. But that's the suction. So this is a, ear, nose, and throat equipment is pretty much the same. So that's the little suction. You can use that in the nose to look at nasal foreign bodies, or you can use that in the ear to suction out debris. Any amount of suctioning of the stuff that's going to preclude us for getting antibiotics down to where we need to be is going to be very helpful. So, and again, this is, you guys aren't there yet. That's okay. That's why it's a 3-year program. But you just be real gentle and brace your hand on their head so that when they go like this, because it hurts really bad, then the whole thing goes out, and you don't do this. That's
Stab him in the brain.
That's not good. Very rarely can we stab them in the brain, but hold that thought, because you can stab somebody in the brain through their ear. Okay. So if it's not a bacterial problem, then it could be fungus. So Aspergillus niger is the most common cause, and you'll get just incredibly thick, nasty debris in the ear, and they have these. This is the niger part. They have these little filiform elements and these little black spore-like formations across that, and the cordyceps has a antifungal agent in it, and that's why we use cordyceps to begin with, because we don't know if it's a bacteria or a fungus. The over-the-counter swim ear products are pretty good. You can use those too. Those most of them have aluminum acetate or calcium carbonate and acetic acid associated with them. There is a particular type of patient that you need to be very aware of. So if he shows up in clinic and he has extreme tenderness, swollen canal, you need to go, okay, this is not the let me put in a wig and give him some drops and maybe some pain medication, and we'll let the ear, nose, and throat doctor see him on Wednesday. This is the I need you to see this patient or tell me who to send this guy to really, really, really quick, because I'm afraid he might die. So those are usually patients that you're interested in, right? So who is that? It's the immunocompromised patient. So what is the most common cause of immunocompromise that we know of?
HIV.
HIV? It is a cause, but not the most common cause.
Cancer.
Not the most common cause.
Medication?
Who said diabetes? Tomorrow I will bring you a payday.
Oh.
Right,
Payday.
right, because that's what we're all going for, right? Friday's payday.
Not for 2.5 years.
What's that?
Not for 2.5 years.
So diabetes is the most common cause of immunosuppression. So you need to just recognize that. So the diabetic otitis externa patient needs some really, really gentle attention. So the reason for that is because the skin can necrose. It can necrose the bone, and it can get into the bone, and it can set up a situation where you have osteomyelitis of the skull. And I have one patient who we treated for 24 months on IV antibiotics in order to get him clear of that. We knew it's always bad when you have named syndromes to the cranial nerve deficits that he had. So you have to just be aware that if otitis externa, immunocompromised patient, HIV, absolutely. Immunocompromised patient, cancer patient. I just got a phone call about a guy who had AML and both sides really bad otitis externa, and he had a facial nerve paralysis. So, how does that happen?
Because the vestibular and the facial go through the same canal.
They do. So the vestibular nerve and the facial nerve go through the internal auditory canal. There are 4 things in the internal auditory canal. Can we name them? Facial nerve, very good. Facial nerve, I'm done. Okay, so facial nerve, right? Yeah, so the 8th nerve, and then there are actually 2 vestibular nerves. So there's a superior vestibular nerve, there's an inferior vestibular nerve, and there's a cochlear nerve, but they all just become one big happy family, and they just get only one designation, the 8th cranial nerve. So there are 4 things inside the internal auditory canal, but one of those things goes beyond the internal auditory canal, and that's the facial nerve. Where does the facial nerve come out? Who's ever mumbling, the stylomastoid foramen is correct. There we go. Nice job. So, and where's the stylomastoid foramen? So your mastoid is right here. Okay, it's underneath your mastoid. So your mastoid tip protects the facial nerve. Where does it go between here and there? Yeah. This is why we have these classes. It goes through the middle ear. Okay? So there is a transtympanic course to the facial nerve. All right? So when I was teaching the residents at the University of Oklahoma, they would give me a hard time, and the reason that they would give me a hard time is because they were actually learning something. But I would say that, remember, it's all about the facial nerve. Okay? Because facial nerve is mimetic movement. That's smile, pucker, frown, look angry, protect your eye. So we do not want to have to send these people to ophthalmologists. So you blink your eye with your facial nerve, you open your eye with a different nerve. It's a great system. So immunocompromised patient with a facial nerve paralysis and an otitis externa is likely malignant otitis externa. Okay? Anybody know anything that is good that's named malignant? No. Why? Why is it malignant?
Moved from its original spot.
Moved from its original spot. But the reason that it's malignant and it's named like this, it's not a malignancy. But it's the reason because it carries a very, very, very high mortality. So untreated, the mortalities can approach 50, 60, 70, 80%. So, and we're talking big time surgery, facial nerve decompression, canal wall down mastoidectomies, which I'll explain what that means. Big time, deep surgery to try to decompress the skull base from these things. So, facial nerve paralysis, immunocompromised. It's all about the facial nerve because the facial nerve goes through where? Stellomastoid foramen, but it goes through the middle ear. Right, so it goes through the middle ear. Okay, and I can tell you just, gut-wrenching, heart-wrenching stories as to why do instructors develop quirky sayings to teach to students? Because they've had a patient that has, hit them right here. You guys will have those patients too. Okay, so skull base osteomyelitis, elderly, diabetics, immunocompromised function. So this is one of those patients, just really ugly, severe granulation tissue. So granulation tissue is the body's attempt to correct this problem. It is trying to heal it. It's really friable. It will bleed a lot when you try to suction it. We do CT scans and MRIs and technetium-99 scans for diagnosing these things. We do cultures, hyperbaric oxygen, operations, admission to the hospital. There is a thing called medial canal stenosis. So if you look in the ear in an adult, these are usually adult patients, look in the ear and they're like, I don't see the eardrum. So you can develop an inflammatory process from chronic otitis externa where the ear just walls itself off. And this is a really, really challenging operation to try to recreate the external auditory canal. Okay, this is a little baby with just atopic dermatitis that can affect the ear. Psoriasis can affect the ear. Lupus can affect the ear. Okay. Don't use Q-tips unless you want to come and see us. Okay, so that's the end of the otitis externa lecture. Babies can be born with malformed ears. We call that microtia. Microtia can be also associated with atresia of the external auditory canal. So when you do your pediatric rotations and you're looking at the newborn babies and you're looking in their ears and doing their newborn hearing screenings, occasionally one of those babies will have an atretic canal. That's not an emergency. That's just an interesting finding for a while. We usually try to fix those or do some sort of a hearing device for those at the age of 5 or 7. So the ear and the kidney are linked. So there are things called branchio-otorenal syndromes. So just think to yourself, if there's an abnormality in the ear, you might also need to just think about the kidney. Another common thing that we'll see in the external ear is wrestler's ear or auricular hematomas. Those are a little bit of an emergency. We like to see those and take care of those so that the cartilage doesn't die. So everybody know what I'm talking about? So, the really cool wrestlers don't wear headgear. So that they get these funny little crumpled ears. And so when they show up to my clinic with their mommies, they're like, oh, I don't want it taken out, I want the ear. I'm like, but you're gonna take wedding pictures someday, and your wife is not going to be happy. Anyway, but those are reasons to, to phone up somebody who can take care of that. In general, if you're in Stringtown, what you should do is numb it up with a little bit of lidocaine. So you numb up the skin right over the hematoma. And the hematomas are usually just on the outer edge. I don't think I've ever seen one on the back edge. But you're going to want to numb up the ear and stab it with a very large needle and suction out the blood. And if you can't suction out the blood, then you've done everything that you can. And you can send them to me, and I'll make a big incision and squish it out and sew it together. What I usually do is I'll say that the hematoma is right here. Well, there are areas in the body called relaxed skin tension lines. Those are the places that you want to put incisions. You can Google relaxed skin tension lines, and you can see the menagerie of how they go. But in the ear, all the lumps and bumps and hills and valleys have names, and we're going to put it right along one of those prominent points in order to camouflage it. So we'll make an incision, and then I'll take a dental roll. Anybody had their wisdom teeth out and had dental rolls crammed in their mouth? I'll suture a dental roll on top of the hematoma, and then behind the ear, and then into the scalp, so that it doesn't move. I'll leave that on for 3 or 4 days, and then have them back and cut it off. But in general, if there's a hematoma, a collection of blood somewhere, you want to stab it and drain it and try to decompress it. The reason that you want to do that is because the pressure can kill the cartilage underneath the skin, and dead cartilage and a floppy ear are even less cool than the hematoma. Okay, so let's review. Do we use Q-tips? No. Are we big fans of lotions and potions in our ears? No. Because cerumen is what? Normal. When are we really worried about somebody with otitis externa? When they're immunocompromised. If there's otitis externa and a facial nerve paralysis, we're really worried because it might be malignant otitis externa. And the facial nerve goes through and it's all about the facial nerve. You may, 40 years from now, you may go, there was this guy. Okay, so let's take a 5-minute break, and then we'll do otitis externa. Then we'll do otitis media. Otitis externa is like the least fascinating thing that we'll talk about.